So, first of all, I'd like to thank the organisers for inviting me to talk on the topic of cardiomyopathy, and particularly these three different types of cardiomyopathy, which, as Ian said, are some of the less well-recognised types. There's LV non-compaction, there's restrictive cardiomyopathy, and there's the curiously named Takotsubo cardiomyopathy. This is where I work. I work at Bristol Children's Hospital and the Bristol Heart Institute. I'm one of these curious creatures. They don't make us anymore. I work with both children and adults. I trained in paediatric cardiology and also in adult cardiology, and you're not actually allowed to do that anymore, which in some senses is a pity. In the Children's Hospital and the Heart Institute, I'm a cardiologist, and I'm also an electrophysiologist, which means I deal with funny heart rhythms, which will be particularly pertinent as we'll come on to. I put in pacemakers and burn away fast heart rhythms. And that's what I do. I also have an interest in exercise. As part of my extended midlife crisis, I rode the Atlantic this time last year, actually. Don't ask me why. It was because it was there, I suppose, is the answer to that one. And as part of that, about 15 years ago, I started seeing athletes with heart problems, because many athletes who have heart problems, they see a cardiologist who immediately tells them to stop doing the exercise, which is often the wrong advice, not always, but often. And so I see them in a little company called Sports Cardiology UK. I'm also on Twitter, and I put that up for a very specific reason, because I'm desperately trying to catch up my son in the number of followers. He is beating me hands down at the moment. So if you can, even if you just unfollow me immediately afterwards, that would be marvellous. No competition there. And as you can gather from my story, I am a very, very important cardiologist. All cardiologists regard themselves as very important, and I am no different. But actually, I have another qualification for giving this talk. As I said, I'm an electrophysiologist. I deal with funny heart rhythms, and I'm also a patient. This came upon me rather recently, and that, I think, is even more important, because perhaps it gives me a little bit of an insight into what some of you guys are going through. On my wrist here, you'll see a thing called a Charge 5. This is a Fitbit. And there's a number of different devices now available which allow you to monitor your ECG. And they're actually generally very good. Not the knockoff £20 ones from China, but the Apple Watch, for example, the Fitbit Charge 5, the Withings Move ECG. There's a number of these. And as I see athletes who are all very interested in data, they all bring along their ECGs. So I decided to get one myself. I try them all out, see if they work, which generally they do. And this was my ECG a few weeks ago. Now, I don't expect you to understand all these things. This is the Fitbit Charge 5. It costs about £100. In fact, Black Friday, it's less than £100. I have no shares in Fitbit. And what this rhythm shows is technically it's atrial flutter. So there's an irregular rhythm here. You can quite clearly see that these are at a different rate to these. And these are these big extra beats. These are ventricular premature beats. So like many of you, I will, as an electrophysiologist, will be going through a procedure which I do to my own patients. So I chose my cardiologist very carefully. He lives 2 doors up from me, close enough for me to smash his windows if he makes a mess of it. So, back to our topic. LV non-compaction, restrictive cardiomyopathy, and Takotsubo. And I've linked each one of these to a picture, and hopefully you'll see why the picture is linked to them. So LV non-compaction, you'll recognise this athlete here. This is, of course, Homer Simpson in his athletic phase. And that's because there is an overlap between some of the features you get in normal healthy athletes, particularly black athletes, and LV non-compaction. And that does make it more challenging sometimes to make the diagnosis. Restrictive cardiomyopathy, I've linked to this one. This is, of course, a hen with teeth. And I don't know if anybody's seen a hen with teeth. I doubt it, because they're extremely rare. Hence the phrase, rare as hen's teeth. And restrictive cardiomyopathy is probably the rarest of cardiomyopathies, particularly the one that's purely genetic in etiology. And the third one is Takotsubo cardiomyopathy. It's the one with the most curious name. And this is a Takotsubo pot, and it's used by Japanese fishermen for catching octopuses, octopi, plural of octopus. And you'll see why it's known as Takotsubo cardiomyopathy when we come on to it. So the nature of cardiomyopathies are that they have a genetic element. Some of them are purely acquired, and some of them have a mixed component, partly genetic predisposition, partly the effect of the environment. And if we look at LV non-compaction, this is from probably the last big consensus paper on the classification, the original classification of cardiomyopathies from Barry Marin in 2006. LV non-compaction would be regarded as largely a genetic cardiomyopathy. If you look at restrictive cardiomyopathy, that has both genetic components and acquired components. So, for example, some forms of restrictive cardiomyopathy, particularly the ones that appear in children, extremely rare, are almost entirely genetic. Others are largely due to acquired diseases such as sarcoidosis, and they're much more due to environment. And then thirdly, there's the so-called, and probably poorly named, stress-induced Takotsubo cardiomyopathy, and that's regarded as largely an acquired disease with no genetic component. But the older I get in life, the more I realise that nothing fits into easily defined categories. And in fact, genetics and environment constantly interact. So even conditions such as LV non-compaction, where you would regard that as largely genetic, you can have people with the same gene who have entirely different manifestations. So you can have a mother with very mild cardiomyopathy and their child with the same genetic change who's got very severe cardiomyopathy, or sometimes even the other way around. So genetics do matter, but also environment can interact with it. Similarly with restrictive cardiomyopathy and Takotsubo cardiomyopathy, one of the questions is this a genetic predisposition to this particular cardiomyopathy, or is it purely due to environment? And probably there's a bit of both. So going through each section, and do feel free to stick a hand up and say, what are you on about? What I'd like to do is look at symptoms, causes, diagnosis, management and treatment, and then the issue regarding genetic testing for family members. And by symptoms, I'll be talking about how it affects you. What do you feel? As we heard that wonderful talk just a few minutes ago, you present sometimes with breathlessness, palpitations. How does it present? And there's a lot of overlap between the different cardiomyopathies, and many of them present in very similar ways, so that symptoms often are not distinguishing features of an individual cardiomyopathy. Secondly, causes. Why has the cardiomyopathy developed? And there's still an awful lot for us to learn. We're learning more and more year by year, particularly in terms of genetics, and it's amazing that we've now got this £30 million grant to look in the genetic etiology of cardiomyopathies, but there's still an awful lot more to learn, particularly why one cardiomyopathy behaves in one way in one individual, whereas in another individual it behaves in a completely different way with apparently the similar gene. And that may be the effect of environment, it may be the effect of one of the other 25,000 genes that we all have, or two of the others. It may be that there's modifier genes plus the primary gene that causes the condition. So why is it there? Thirdly, diagnosis. How do doctors make the diagnosis? What tests do they do? How do they become sure as to what was happening? And again, in the talk we heard this morning, the lady, I'm sorry I forget her name, but when she was speaking so eloquently, she described how she was going for surgery. I presume that was for a leaky valve, when suddenly the penny dropped that it wasn't the leaky valve that was the problem, it was the enlargement of the heart which was causing the leaky valve, and hence surgery would not have been the treatment. How do we treat it? And again, there's huge advances in the whole area of treatment. A lot of overlap, a lot of similarities, but some differences between these different cardiomyopathies. And finally, the whole issue of genetic testing and family assessment. And that's not quite the same thing. We know the human genome was mapped about 15 years ago. We know we've got about 25,000 genes which are coding for proteins. The way I tell my patients is you think about the genetic code a bit like a recipe book for producing proteins. In the recipe book, there's chapters. In the chapters, there's pages. And in the pages, there's sentences, and each sentence consists of words, 4-letter words, and that's the equivalent of a gene. And if you have a spelling mistake in one of these letters, that can sometimes produce a change in the protein, which may have no effect. It may just cause a family resemblance. Some families all have sticky out ears or big noses. That's probably a genetic effect. Or it may affect the protein such that it affects the way the heart functions. So the genetic code is very important. But also, there's this balance between phenotype, which is the way the cardiomyopathy presents, and genotype, which is our genetic background. They're not quite the same thing. And what's most important is phenotype. Genotype is helpful, but most important is phenotype. So for some families, you may have no genetic cause found. That doesn't mean you cannot look at your relatives. It means that you have to use things like echoes and ECGs and things. You can still make a diagnosis without a genetic change. So does my family have it? So this is where I hold my breath and hope that this works. So let's just remind you about the normal heart. So this is the heart beating, and there's 4 chambers. Basically 2 pumps side by side. One pump takes blue blood and sends it out through this blood vessel here to the lungs. In the lungs it's given oxygen, then comes back through the lungs through a top collecting chamber and a bottom pumping chamber and round the body. So that's the right ventricle, that's the left ventricle. So it's a very clever electrical pump. And by electrical pump, this is the electrical side of it. I tell my patients to think of it like wiring. It's not wiring, it's modified muscle. The yellow is the wiring, specialized muscle that depolarizes quicker than the rest of the myocardium. And you can see that it starts off up here. That's a specialized bit of muscle called the sinus node. That's what's sensitive to things like adrenaline. So if you're running, your heart produces adrenaline. It goes in the bloodstream to the sinus node, tells you to speed up your heart rate. It then goes through these top chambers, causing the top chambers to contract. That's a kind of junction box between the top and bottom chambers called the AV node. And then it goes down through this network of pathways down to the bottom chambers, and the bottom chambers contract. So it's top chambers, then bottom chambers like that. And this is the ECG. This is what I'm sure anybody here with cardiomyopathy has had. And what you've got here is this little bump. And that's the top chambers contracting as the impulses go from here to here. There's a gap here, and that's as the impulses go through the AV node. There's this big spike as it goes down to the bottom chambers. That's the ventricle contracting. And this is the repolarization. So if you remember back to my ECG, you can see it didn't look quite like that. And so that's the normal sinus rhythm. So that's a bit about the normal heart. Let's now consider LV non-compaction. Now this little cartoon, which comes from a patient information leaflet from Cincinnati Children's Hospital, shows the normal heart in a sort of diagrammatic form. So what you've got is the right ventricle here, that's the one that pumps blue blood to the lungs, and the left ventricle here. And the right ventricle has got these sort of crevices in it, whereas the left ventricle tends to be much smoother. A smooth-walled left ventricle and a heavily creviced or trabeculated right ventricle, and that's the norm. But this is what happens in LV non-compaction. The left ventricle, instead of being smooth-walled like that, has these trabeculations or crypts. And actually we have all had these at one point in our lives. That's as a fetus. Because in the fetus, the blood supply to the heart muscle goes through these crypts. We don't have coronary arteries coming off the aorta, or they're not fully developed. So blood supply to the heart muscle goes through the crypts. And so this is a kind of fetal type of picture that you don't normally see in an adult, because as you develop in the womb, as you develop in the womb, these crypts disappear. So this is very similar to fetal life. And non-compaction, compaction is the process by which these crypts disappear as you move into a fully formed heart at birth. And so it's non-compaction, they haven't disappeared. So let's go back to these questions. How does this condition affect you? What are the symptoms? And some of you may point out symptoms, and please feel free to do so, that you've had that are not on this list. But these are some of the symptoms that may first give you an inkling that you've got a problem, such as LV non-compaction. Shortness of breath and fatigue. Most Saturdays I feel a certain amount of shortness of breath and fatigue, and that's due to doing a very busy Friday clinic. And that doesn't necessarily mean I've got cardiomyopathy, but if you're very short of breath, if you need pillows in order to sleep, then that's a sign that your heart is not pumping efficiently. That's because fluid builds up in the lungs. Instead of going through from the lungs into the left ventricle, there's a higher pressure in the left atrium, in the collecting chamber in the left side of the heart. Therefore, the lungs, which should be like a sponge full of air, don't empty, they're soggy, and you have to breathe faster to get the same effect. Feeling dizzy or lightheaded, that's because your blood pressure is low, either because you're having a fast rhythm or because the heart's just pumping inefficiently. It's not pumping enough blood out. Fainting or passing out. Passing out is always a slight concern. If I hear of a patient with a cardiomyopathy, or indeed any patient who's passing out, then it raises awareness. Now, 1 in 4 teenage girls faints. It can be an entirely normal phenomenon. And usually it's in the hot, stuffy atmosphere, it's in the situation of stress, for example, giving a talk to a bunch of cardiomyopathy people at a conference. That's the common. Soldiers at attention for many hours, and there's a beautiful picture of a soldier guarding the Queen's funeral who went completely flat out, and that was a vasovagal faint. That's normal. But it's quite different. If you hear somebody who's taking part in a 10K run, they're running along, they go down. That's a red flag. Anybody who passes out during exercise, that's a big, important sign. That's syncope, fainting during exercise. Feeling abnormal heartbeats, very common, and palpitations is one word that we use for that. And unexplained weight gain or swelling, and that's exactly what we heard this morning. She was putting on weight, she couldn't shift it, and that's because that weight was not fat, it was fluid, and you can't shift fluid by cutting down what you're eating. So these are some of the symptoms. And this condition can present in babies. And babies present in a rather different way to adults. Babies don't tend to do very much, but they eat. And so when they've got cardiomyopathy, they often get breathless when eating, and they show itself by just not being able to eat properly. They don't gain weight. They're very sweaty during feeds, and they've poor growth. So these are some of the symptoms that you get from LV non-compaction cardiomyopathy, and there's a great deal of overlap between that and many other forms of cardiomyopathy. Sometimes, however, there may be no symptoms. You may have a cardiomyopathy and have no symptoms whatsoever. You may feel entirely well. That's not always reassuring, because you can still sometimes have a potentially dangerous abnormal rhythm, even if you've got no symptoms of breathlessness or sweating or palpitations or fainting. Right, so this is a normal rhythm. You see the nice normal QRS, P wave QRS down here. And then suddenly you go into this rhythm here. This is ventricular fibrillation. And this is a fast, irregular rhythm. And when that happens, you faint. And the reason you faint is there's not enough blood getting to the brain. The body responds by making you lie down. There is no drug therapy that prevents ventricular fibrillation. If you have ventricular fibrillation, you need a defibrillator. And we can come on to that a little bit later. So we've talked about how it affects you. These are the symptoms. Why is it there? The $64,000 question. Why do we get these things?
Yeah, I just have a quick question.
Of course you can, yeah.
Just so, from an LVNC perspective, exercise, HRV, heart rate variability, does the weird ECGs that we have, is HRV something you cannot look at because of the way it's measured? Because I think, as a family we've got LVNC and we're fairly active, and I get the feeling my HRV is actually the reverse of what you would see normally. So I think my HRV goes up whenever I've actually got a problem, as opposed to indicating recovery, and vice versa. So I don't know if
Right, and that's interesting. So HRV is heart rate variability, and that's a normal phenomenon, and it's something that For example, children have much bigger heart rate variability than adults. If you want to know if you've got heart rate variability, if you feel your pulse, take a big breath in, your pulse will increase, take a big breath out, and your pulse will decrease. That's heart rate variability. If you're overtraining as an athlete, you get less heart rate variability. And yes, I'm sure it can be affected by cardiomyopathy because it's due to the autonomic nervous system, which is not the adrenaline-based nervous system, it's something called the vagus nerve that slows down the heart. So my problem from doing too much exercise over the years, like doing silly things on the Atlantic, meant my heart rate was going too slowly, high vagal tone, therefore the escape rhythm was an abnormal one. And so I think it may well be the case. I haven't heard that before, but I think you may well have hit on a new physiological parameter here. So it may well do that. That's not to say you can't get to know your own body. So you'll pick up what works for you. And I think HRV would be an interesting thing to monitor. I've not heard of anybody looking at that in people with LVNC, but I think you've got to speak to Professor Elliott. He may be very interested for his next research fellow to have a look at that. So yes, HRV is a modality. Again, you can check that in watches. If you wear a chest strap when you're exercising, some of them will give you HRV. So when we're looking at the causes of cardiomyopathy, in genetic causes, LVNC would be regarded as primarily a genetic cause by this paper by Barry Marin from a number of years ago. And in fact, there's somewhere between 20 and 40% of families you identify a specific genetic change. And interestingly, sometimes that genetic change can cause LVNC, say in the adult, and restrictive cardiomyopathy in the child, or hypertrophic cardiomyopathy. There is an overlap between the different types of cardiomyopathy and the individual genetic change, and we're not quite sure why that's the case. But somewhere between 20 and 40% of a genetic cause. As time goes on, I'm sure we'll find more genetic causes. At the moment, when we look for a genetic cause of cardiomyopathies, we look at a certain number of targeted genes, not all 25,000 genes, but that is something that we can do and may well develop in the future. And some of you may have been part of the 100K program, the whole genomic testing, which pretends it's looking at 25,000 genes. In fact, it's not. It's just looking at a much smaller number of genes, but can look at all the others as knowledge advances and we learn about more genetic changes. LV non-compaction usually only affects the heart. Not always, but almost always, it's just affecting the heart. It doesn't tend to be associated with other body system problems. But rarely, and particularly there's a condition which affects boys called Barth syndrome. It's rare as hen's teeth, to use that term again. In fact, the UK Barth Centre is based in my own unit in Bristol, and there's about 20 boys with Barth syndrome in the United Kingdom, very small. And that's a metabolic condition, and there's a specific test for it, and there's slightly different treatments, and that can have other features as well. It's X-linked, which means that boys get it, the X chromosome from their mums. What about athletes? I mentioned this famous athlete, Homer Simpson. What's the link between athletes and LV non-compaction? Well, Sabia Gatti, who's a consultant, I think Sabia's now in the Brompton Hospital, has a particular interest in LV trabeculation. And when working with cardiac risk in the young, she looked at a large number of athletes. They looked at 1,000 athletes, and 18% showed increased left ventricular trabeculation. And 8% of those fulfilled the criteria for LV non-compaction. Now, 8% of athletes do not have the condition LV non-compaction. And so clearly there's something about exercise that can bring out these changes, particularly in black athletes as opposed to white athletes. And this was the paper which Dr. Gatti produced. And so together with Sanjay Sharma, who's based at St George's Hospital, who's done a lot of work with athletes, they came up with this idea that with an athlete who's got the LV non-compaction type of pattern or the hypertrabeculation, you need a triad of things. You don't just need the echo changes, and this is really important because, for example, every footballer in the country gets screened as soon as they get their professional contract. If you pick up one with increased trabeculation, that will stop that person's career. So you've got to know, is this a condition or is it just exercise? So you need to have fulfilled the criteria on the echo, for example, plus, excuse me, have ECG changes, plus have reduced heart function. So just having the echo changes would not be regarded as enough. And obviously there's other tests that you can do in due course. So that's why is it there? How is it diagnosed? And many of you will have gone through all these tests. And this is an echocardiogram showing the increased trabeculations. This is a normal echocardiogram. You see a relatively smooth wall. So this is the left atrium, blood coming back from the lungs into the main pumping chamber that then goes out around the body. This is the right atrium, blue blood coming back from the body into this smaller pumping chamber, going round into the lungs, given oxygen, and so it comes back on this side. Smooth walled here. And here you can see the little crypts. And that's an example of hypertrabeculation of the left ventricle. So echo is a very useful, non-invasive way of looking for this. But there's an overlap, and one of the problems we've got with echo machines is that they're getting better and better. So we're seeing all sorts of crypts, which in the past we wouldn't have seen simply because the echoes weren't sensitive enough. And so MRI scan can be very helpful. And this is an MRI scan showing the left ventricle. This is a cross-section, so it's cutting it across in that direction. And you see the increased crypts here in the left ventricular myocardium. And people have come up with various ways of assessing this. You can measure the area of or the distance of the non-compacted part to the compacted part. Greater than 2:1, some people would say, is diagnostic. In fact, in practice, it's very difficult to make that distinction. Imagine trying to work out where one bit starts and one bit stops on that particular echocardiogram. And there's been a number of different diagnostic criteria produced for LV non-compaction. But like many things in medicine, it's not an absolute science. And what we're in the business of in medicine is pattern recognition. So you can make all these measurements, and we do, but you have to take into account, are they athletic, are they non-athletic? Is there a family history? Is there not a family history? Do they have an abnormal ECG, etc.? So we're in the business of looking at patterns. And this is a good example of pattern recognition. You probably recognize this. Even a non-medic could recognize that this is, of course, Homer's X-ray. So how is it diagnosed? How is it treated? And again, there's overlap between LV non-compaction and some of the other cardiomyopathies. And treatment will be, firstly, involve treating the heart failure. Heart failure is a bad term. The heart's not necessarily failing. Most of my patients have got some degree of heart failure. That doesn't mean the heart's about to stop. Heart failure is probably better described as heart inefficiency. So the heart's not beating efficiently enough, therefore the blood's not getting through the heart, therefore it's building up either on the right side in the abdomen, so you get a big distended tummy, you get a big liver, you get swollen ankles, or it's building up in the lungs, which means you get breathless. And to treat heart failure, you're sometimes given diuretics, which just make you pee more. And by taking off the fluid, then that will make you less breathless, it will reduce some of the swelling of the tummy and so on. It doesn't treat the cause, but it can make you feel a lot better. There's drugs like ACE inhibitors, captopril, lisinopril, ramipril, and they have a number of different ways of acting. They, for example, will reduce the afterload, which means that they relax the blood vessels in the arms and the legs, which make it easier for the heart to pump outwards. Interestingly, exercise does something very similar, and my research interest is largely in promoting exercise in patients with heart problems. And when you exercise, when you go for a run or walk upstairs quickly, your hands and feet get warm. They get warm because the blood vessels dilate. ACE inhibitors work in a very similar way. And so there's a role for exercise treatment here that has to be very personalised and specific in people with cardiomyopathy. And then there's a variety of other drugs. Spironolactone is a diuretic, but it has another effect. There's drugs like Entresto, and there's a whole host of new anti-heart failure drugs which are increasingly effective in treating the symptoms, but seldom treat the cause. Beta blockers are another one. You can treat the slow heart rates, and that often involves a pacemaker. So a pacemaker is just a box that goes under the skin attached to wires that go inside the heart. Or in fact, nowadays, we can actually put the pacemaker inside the heart itself, a leadless pacemaker. And sometimes, particularly in patients with heart failure, you'll get a pacemaker with 3 wires, one of which goes on the right ventricle, one of which goes inside the left ventricle, and one of which goes in the top chamber. And what that does is it allows the heart to contract in a synchronous manner, because often in heart failure it's going like that, which is a very wasteful way of using energy. In a biventricular pacemaker it goes like that. And that was a big game changer when it was first discovered a few years ago. And then you can treat fast heart rates, and that may involve medicine, or it may involve a defibrillator. And if I show you what I mean by that, so same sort of diagram or little cartoon. I hold my breath and see if it works. So here you've got your normal rhythm. There it's going to fast rhythm. Now if this happened in hospital, what would we do? Well, you've all seen it on Casualty and Holby City. What they would do is they'd get a couple of paddles and zap it back to normal. And that works very well, but in practice, a defibrillator is having an implantable series of paddles or implantable ambulance team. So there's a box goes under the skin, goes into the fast rhythm, and it shocks. And it shocks between here and here, or sometimes between here and here. And that is life-saving. If you have a malignant, very nasty rhythm, having a defibrillator is life-saving. You don't want one if you don't need it, but if you do need it, it's life-saving. So that's how it's treated. Then the big question, does my family have it? Have you got a family history of it? Are your children at risk of it? And so with this cardiomyopathy, as indeed with most cardiomyopathies, we'd recommend that screening of all cardiomyopathies, screening of first-degree relatives, that is parents, children, and siblings, is carried out. So if you've got a cardiomyopathy and your first-degree relatives haven't been screened, then they should have been. And one of the problems we have in British medicine is that the doctors tend to treat the patient in front of them. But actually, in inherited cardiac conditions such as cardiomyopathy, very much we're dealing with families. And so there needs to be a family approach to this. So for example, you may remember the broadcaster David Frost. David Frost lived to his, I think, probably late 70s, maybe even 80s. When he died, he was found to have a hypertrophic cardiomyopathy. That should have led to his family being assessed, and it didn't. And so his son, Miles Frost, went for a run aged early 30s and tragically had a cardiac arrest and didn't survive. And that led to the Frost family raising money for cascade testing of families. So the Miles Frost Foundation, they raised money so that we have one of our nurses is funded by that foundation, so that families will be seen. And it's a lot of extra work. It's difficult stuff to do. It's very time consuming, but extremely important. So screening of first degree relatives. And that can be either phenotype, which means ECG, echo, maybe an MRI scan, assessment of what the patient's symptoms and signs are, and also genotype, and that's the genetic test. And that can be helpful if there's known to be a genetic cause which has definitely caused the condition in an individual. Then you can look at that individual's family for that genetic change. Trouble is, genetic changes are not always binary like that. They're not always absolute. So you may have a genetic change that definitely caused it. You may have no genetic change found, or you may have this awful thing called a variant of unknown significance, VUS. And that's where you've got a change in the gene, but you don't know if that's caused the cardiomyopathy. And there's various ways that we predict whether or not a new change in a gene can cause a cardiomyopathy. We use something called in silico tests, which is basically just computer prediction. You look and see if that genetic change is in the normal population. If 10% of the normal population have got it, it probably isn't relevant. If less than 1 in 10,000 have got it, it might be. And so phenotype is king over genotype, but you need to do both. And in NHS England, Genomics England, they use this thing called the R132 panel. There's around about 32 genes, I think, on it at the moment. But that changes all the time. As we learn about new genes that are definitely the cause, then we look into that. So that's screening of first-degree relatives. So that's, yeah.
Can I just ask about screening? How often should it be repeated in siblings or children?
I mean, that's a very good question. So for children, what I would normally do, and there's a variable approach to this, I would normally say, supposing a parent has got one of the cardiomyopathies, say LV non-compaction, I would see the child before they start school. And the chance of them having a problem then is very low. It's not zero, but it's very low. Theoretically, they're at 50% risk of having it. The reason for seeing them before they start school is because you want to know when they go to school, can they do everything all the other children can do? If everything's absolutely normal at that point, I would see them 3 or 4 years later, certainly before they head to senior school, for exactly the same reason, because they then start to get, if they're into sport, they start to get a bit more serious in their sport and so on. Obviously, if there's a genetic test, then you can consider doing that, but you'd only do that in a child if it was an absolutely definitely pathogenic mutation. Puberty is a difficult time because that's when changes happen very quickly. So, for example, in hypertrophic cardiomyopathy, we would monitor them at least annually over puberty. And then you'd see them when they're fully grown. By that stage, hopefully, it'll be clear whether or not they've got the condition. But sometimes you have to continue to see people as adults every few years when, for example, something has presented maybe in middle age and there isn't a genetic test. So that's my approach. People vary slightly, but that seems to work fairly well, I think. So that's LV non-compaction. Any other questions about LV non-compaction?
Sorry, progress, but I'm going to take my opportunity.
That's okay.
So, what's the trajectory or prognosis for LVNC? Because that's one of the things we're really struggling with, is like, what's the future hold for people with LVNC in the same, we don't have known it for so long, we haven't got many cases, sort of thing. So, what is this sort of, what can we consider the future's going to hold for us?
It's very variable, and that's part of the problem because there's a whole spectrum. So if a family is found with LVNC, sometimes, for example, I have one patient who's a young child, the mother's got it, has no symptoms whatsoever, and may never get symptoms. The grandfather's got it as well, has never had a symptom, yet the child's got it and has heart failure symptoms. So it's very, very variable. And so it's frustrating, but it's quite difficult to give a precise prognosis. There are things you can look for. So, for example, if the heart's contracting well, then that's a good sign. If it's very poorly contracting, that's a bad sign. So some patients will go on to need heart transplants, and some patients will never need anything done. And if we could work out why some people do well and some people don't, that would be a huge advance.
I mean, can I just share something that might be relevant to people in here with LVNC? But I went for my annual checkup 2 months ago and got the echo, and the ejection fraction for myself had dropped to 30%. So that was like a 10% drop over a year, which then put me into severe heart failure. I never no kicked off, ICDs, blah, 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 right? I got the MRI 2 weeks ago, and my ejection fraction is actually 44%. So I just think that if anybody's going through an echo, and you're getting the echo numbers on your ejection fraction, you've got to be really careful what intervention is taken on that, because I'm not an echo expert, but they keep on telling us it's really difficult to measure, which we get, but sometimes on the back of that measure, they're making big decisions on how they're going to treat you going forward. And I don't know if you believe it is MRI the gold standard and you wouldn't do any sort of intervention until you've taken the MRI. Would that be your view on that?
Well, I mean, it's interesting. You're making a very good point. If you look at all the research trials, they're based on ejection fraction in very clear percentages, less than 40% you get defibrillator, etc., etc. If you ever try and measure an ejection fraction, it's a bit like measuring how big somebody's ears are. It depends where you put the points, outer and inner and all the rest of it. And it's an art, not a science. And that's why you need to look at the pattern. And so beware of anybody who's doing a procedure on the basis of one measurement. MRI gives you a bit more precision, I think. Some people are very good echo windows, and it's very easy to see. Some people are very poor echo windows. And the way people measure ejection fraction in echo varies hugely. There's about 4 or 5 different techniques you can use. And you'll find one guy saying, it's 30%. Next person looking exactly the same echo might get it to 40%. So there's a difference to what they get in research trials where it's one very focused individual doing exactly the same measurement every time. So yes, you have to have the pattern. And if it doesn't fit with your common sense, say, look, what's the evidence that this has really changed? And the doctors will hopefully talk that through with you. But that's a very good point.
I've got a question.
Yeah.
By the very nature of LVNC, is it difficult to reach EM? I mean, I've got a 3-lead thing, I've got meds, and I'm going down to 15. So is it, I read about other people, and I've done this, it's great, which I know we don't want to get hung up on the figure, but because of how this is this difficult to raise? So
difficult to increase your ejection fraction. Well,
you do everything that you meant to.
Yeah, so the first point is remember lifestyle. And that's really important. So, for example, if you are sedentary and a heavy smoker, then that's going to do you harm. Whereas if you're active, and it's a vicious circle. We've known for many years that people who have heart failure should be encouraged to do exercise, yet usually that's the last thing that happens. And so what happens is sometimes you make no difference to the heart, but what you do is you affect the skeletal muscles. So many years ago, a guy called Hambrich did this study in people with severe heart failure. These are people who could maybe walk across this room. They gave them a clear exercise prescription. And this is not running up mountains, it's just walk for a certain amount of time every day. And they found that they took biopsies from the muscle and the thigh, and they found that the number of mitochondria, which are little energy-producing bodies in the skeletal muscle, had increased both in size and number. What that meant was that the skeletal muscles are working more efficiently. Therefore, even if the ejection fraction doesn't change, you can do more. And so thinking about that, getting all the body in as good condition as you can is really important. It can have an effect on the heart. That depends precisely on the underlying cardiomyopathy. And there's some cardiomyopathies, or one particular, which is the arrhythmogenic cardiomyopathy, where exercise actually makes it worse. But that's about the only one. So most of the others, the ones we're talking about today, generally are better with exercise, although things like restrictive cardiomyopathy, that can be very difficult. Not necessarily, and it's a very specific thing. So it's certainly a conversation to have with your individual cardiologist who knows your situation. Yeah.
So just before you move on, my ejection fraction was 26 when I was first diagnosed, and it's 44 now. Excuse me. I have got a 3-wire pacemaker and an ICD plus medication. So does that mean I can't have an MRI when only now be able to rely on an echo giving me my ejection fraction?
The answer to that depends on the sort of defibrillator, biventricular defibrillator you've got. The much older ones, you couldn't have an MRI, but in fact, the vast majority now you can. So you can actually have one. MRIs are magnetic, and so if they've got ferromagnetic metal in them, then that's not a good thing. However, the MRI can be more difficult to interpret because the defibrillator will cast a shadow, so you don't get as clear images. So it doesn't necessarily mean you can't have an MRI. It may mean that it's less helpful. But things like a biventricular pacemaker and medication can improve your ejection fraction, and that's one of the benefits of particularly biventricular pacemakers and beta blockers. They improve outcome. The heart actually does get better in many cases.
Thank you.
Yeah.
Yeah, from a very different perspective, I've got the LVNC, but I've also got a muscle wasting disease, and they think it's linked. I know it is very rare. I am a one-off, so don't worry that it's you really get it or anything. I'm part of 100,000 genomes, etc. And I've had loads of heart-offs. Have you ever heard of anyone that has got muscle wasting? Because I see neurologists and a bit unusual to say the least. But have you ever heard personally of anyone else having a muscle wasting?
So you're unique, and we're all unique, thankfully.
Yes.
The only condition I know that comes with that pattern is Barth syndrome, but that's X-linked. And so normally a lady with Barth syndrome would be protected by a normal X chromosome. I'm sure they will have looked for that.
Yeah, I've got a chromosomal deletion as well, and I've got, you don't need to know the rest. But it's just interesting because I'm learning more and more and having more procedures with the heart. I've just had one. But no, it's just trying to ask if people have got other views.
I mean, that would be very rare. Outside of Barth syndrome, I've not come across that particular combination. But there will be a genetic cause, and the good thing is we can now look for it. Although in practice, for a new gene, that may take a research lab 2 years to find, so working solely on it. So it's not necessarily an easy thing to do.
No, because the 100,000 genome project, which I've been on for 3 years, they haven't found anything yet, and I know they just keep going. But I just want to know.
Yeah, so the 100,000 genomes, it's interesting. It's slightly unclear how we know that we can go back and look for more genes. It was launched with a great fanfare, but actually how we go back and look at the rest of the genes is not clear. There is no funding for that at the moment. So write to whoever our current health secretary is today.
Sorry, I've just got one more.
Of course, yeah.
Is there an LVNC like specialist in the whole of the country? Like someone that just does specialises in that?
I think most cardiomyopathy units, so what you want is an inherited cardiac conditions centre. And there are a number of these dotted around. Within that, there'll be somebody who's, well, all the consultants in that will be looking after channelopathies, abnormal rhythms, cardiomyopathies, and also things like Duchenne muscular dystrophy, and aortopathies is the other one, big aortas. I'm not aware of anybody who specifically looks at LVNC, although there's some research labs who have a particular interest in LVNC. So if we move on to restrictive cardiomyopathy, this is the hen's teeth one because it's extremely rare in purely its genetic cause. So if this is the same sort of diagram with the smooth-walled left ventricle, restrictive cardiomyopathy, the left ventricle is stiff and the atria, the filling chambers, are enlarged. And so this stiff ventricle, instead of contracting down like that, is contracting like that, which means that the pressure behind it, the inflow pressure is much higher, and that will make the patients breathless. How does it affect the individuals with restrictive cardiomyopathy? Why is it there? How is it diagnosed? How is it treated? And how do you look at the family? Well, the symptoms are actually very similar to heart failure symptoms that you get in LV non-compaction. You may get shortness of breath and fatigue, dizziness, lightheadedness, syncope, persistent cough. That's because the lungs, like a sponge full of fluid, you can't clear the fluid, and abnormal heartbeats. It's very, very rare in babies. I think I've seen only 2 or 3 cases in my career of young children with restrictive cardiomyopathy. That's almost always genetic. And in one case, the father actually had hypertrophic cardiomyopathy. Same gene, different manifestation. And so they again get symptoms of heart failure. Again, there may be no symptoms, but that doesn't mean you can't get an abnormal rhythm that might be dangerous. So the lack of symptoms doesn't mean that everything is okay. So why is it there, restrictive cardiomyopathy? What is the cause of restricted cardiomyopathy? Well, this is the one where there's both a genetic component and there's an acquired component. It lies between the two. Somewhere around 1/4 to 1/3 will have a genetic cause, where we'll find there's a specific gene as a cause. It may run in families, but may appear in an individual for the first time with nobody else affected. And as I mentioned, it can be a different cardiomyopathy in the other family members. And sometimes, particularly in adults, it may be due to a deposition in the heart. So there's a condition called hemochromatosis, where you have a problem with dealing with iron, and that can lead to iron being deposited in the heart, which gives you a restrictive cardiomyopathy picture. And there's ways of treating that, not least by just removing blood, and that removes iron. It can be due to deposition of protein. There's a particular condition called amyloidosis, and there's a specific treatment for that, a genetic treatment, which is for one type of amyloidosis, which is recently developed. And it may be multi-system. There's a condition called sarcoidosis that's behaves a bit like tuberculosis, but it's not infective. It can affect multiple different organ systems, the lungs and the heart. And there may be an inherited cardiac disease. There's a condition called Fabry's disease, which is a metabolic disease. There's a specific genetic test for that and a biochemical test. And there's also a specific treatment for that. And that can cause restrictive cardiomyopathy. So there's multiple different causes, some of which are genetic, some of which are acquired, and there's an overlap between the two. How is it diagnosed? Well, on the echo, here you've got the smooth-walled left ventricle. This is the normal echo here. And this is an echo picture showing a restrictive cardiomyopathy. And you can see that the atria is much, much bigger. See, this is the normal left atrium. This is the atrium in restrictive cardiomyopathy. And the ventricle is much smaller. So you've got these small, stiff left ventricles and great big atria. And so the echo can be quite characteristic. Although That's showing an extreme version, and obviously there's subtle versions of the same thing that are much more difficult to tease out just using echo. You can do a cardiac catheter test where you pass a tube in through a vein using the leg into the heart. You measure the pressure in the heart, and then you find that the pressure in these chambers, particularly the atria, is very high, and the relaxation pressure in the ventricle, not when it's squeezing but when it's relaxed, is also very high. And there's other tests such as blood tests, ECG. You can get an exercise stress echo where you having an echo while you're pedaling on a reclining bike, and also MRI scanning. And sometimes you actually have to take a biopsy of the muscle, and that's where you put usually through the neck, you put a pair of forceps down into the heart muscle. I can see you're all looking a little bit queasy when I mention this. It's actually technically quite simple to do. It's just a little pair of forceps. You snip a bit of muscle, and you look at it under the microscope, and you look for bits of iron or amyloid or whatever else in there. And the ECG can be particularly helpful. This is an ECG here, and you can see what I've circled there is a P wave. Now, normally the P wave is about 1/5 of the size of the sharp spike afterwards, as you see it there. But here, in this particular, the P wave's as big as the QRS complex. That's a sign that the atria are big. So you get big P waves suggesting atrial enlargement. And there's various laboratory tests depending on what you're looking for. So amyloidosis, which is a curious condition. We still don't really know the cause in most people. You can do 24-hour urine tests looking for the amyloid protein. You can look for immune tests, and you can look in the blood for the amyloid. Sarcoidosis, there's a specific test called ACE status. Hemochromatosis, you look for iron binding capacity and various other things here to do with iron. Look at the liver, because the liver is also affected with hemochromatosis. And there's the hypereosinophilia syndrome. That's particularly common in the tropics, where it's due to infestation with a parasite, and that leads to these eosinophil cells, which are anti-inflammatory cells, and that can cause restrictive cardiomyopathy. So there's multiple different ways of diagnosing restrictive cardiomyopathy. How is it treated? Well, it's difficult to treat. This is probably one of the most difficult cardiomyopathies to treat because standard heart failure medication doesn't work all that well. You can treat it, so you can give diuretics to take some of the fluid off the lungs, which can make people feel a bit better. But some drugs, which are good in most forms of cardiomyopathy, ACE inhibitors, they actually make things worse. Because the problem is, if you reduce afterload, these stiff ventricles just cannot cope with it. You may use beta blockers, and they act against adrenaline. They slow the heart rate. They allow the heart to fill. It gives it a longer time to fill, which can improve the overall cardiac output. Blood clots are particularly common. And so with many cardiomyopathies, you may be on blood thinners, such as warfarin or apixaban. There's a number of new medications that are effective, but they're particularly common in restrictive cardiomyopathy, as is heart transplant is often the treatment that you end up needing, particularly in the genetic sorts where there's really nothing like amyloid or sarcoidosis that you can specifically treat. So this can be a very difficult condition to treat. And you can treat the underlying disease. Carol?
Quite large. Would we think it's more of a HFpEF? Would they preserve the ejection fraction, or could the ejection fraction be reduced?
Right, the wonderful term HFpEF. So that's it's basically where your heart failure can be due to the heart not contracting properly, or the heart can contract properly, but it's not expelling properly, if you like. So yes, it can be a HFpEF, but it can sometimes go from being contracting vigorously but not relaxing properly, and then it can then become a dilated phase later on in some cases. So yes, it can. There's certainly overlap between the two. And then if it's due to a specific underlying disease, well, you treat the specific underlying disease. And there's this drug here, tafamidis, which is one of the new genetic treatments. And this is a really exciting area of medicine. That's what the £30 million from the Heart Foundation is going towards. There's this wonderful thing, clustered regularly interspaced short palindromic repeats. Remember that phrase. It's called CRISPR-Cas9 for short. And the reason it's important is what this is they looked at bacteria, and they saw that bacteria, 2 ladies won the Nobel Prize for it a few years ago, not that long ago. They found that bacteria can defend themselves against viruses by snipping out bits of the viral RNA. They've got these kind of molecular scissors. And these very clever scientists thought, well, why don't we use that to snip out bad bits of gene? And this has led to a whole new potential for medications and treatment. So, for example, in Duchenne muscular dystrophy, that very difficult muscular dystrophy where young boys start off normal, they gradually lose the power to walk. It's mostly, they do get a cardiomyopathy, but it's mostly skeletal muscle problems. And then they go on and end up in a wheelchair, and often they die in their teens. 10% of these have what's called a null mutation, which means that the protein is not made. You can use a CRISPR-Cas9 technique to snip out that mutation, and that reduces the likelihood of them being in a wheelchair, not forever, but by several years. So this is a really exciting area of medicine. It's phenomenally expensive, but that will get cheaper. So this is, watch this space for your clustered regularly interspaced short palindromic repeat medications just around the corner. Does my family have it? Well, again, it's phenotype, and you look ECG, echo, MRI, and lab tests. And genotype, if there's a pathogenic mutation, you look at first-degree relatives for that pathogenic mutation. And this is the overlap between acquired disease and genetic disease. These are some of the genes which are involved in restrictive cardiomyopathy, and this is just one particular list. This is a recent paper, but there's lots more around the corner that we still haven't discovered yet. And again, there may be a metabolic component plus a genetic mutation. It may be you need both in certain individuals. So watch this space. So we would do genetic testing, but at the moment the pickup rate is still not all that high. So that's LV non-compaction with the athletes. It's the rarest hen's teeth restrictive cardiomyopathy, a difficult cardiomyopathy to treat. The final one is this curious thing. Sorry. Of course you can. Yep.
You know when you say there's a mix between genetic and environment, what exactly does that mean? Does that mean because I didn't develop restrictive cardiomyopathy until I was about 19, but I was born with my genes. Does something happen in life that triggers the gene fault, or is it just that it gets worse over time?
I mean, the honest answer is we don't know.
Okay.
So you're absolutely right. Your genes, by and large, don't change, although that's not 100% true. There's this thing called epigenetic phenomena, which means that you can actually modify the function of your genes, the way they affect proteins, by lifestyle. So an example would be dementia and exercise. You're born with your genes, your genetic predisposition to dementia, but by exercise you modify the outcome of some of these genes to reduce the chance of dementia. For men, they've not tested it for women, interestingly. So we don't actually know in your individual case. It may be that there's been a virus. Maybe you had a predisposition, plus you had a virus. We know that a lot of the tummy bug viruses attack the heart. It may be you needed both these things. So we just cannot often say. But as I said, that the outcome is hugely variable in all these cardiomyopathies. It may be that you will stay static. And
I've had a transplant.
Oh, you've had a transplant. Yeah. I thought you were looking very well.
Yeah, I don't have it anymore.
So you've got rid of it.
Yeah, it's gone.
So, that's a case in point. But we just don't know what makes some people progress, because presumably you had the predisposition to this all your life. And we just don't know. I appreciate that's not very helpful. Yes?
I will also ask, my granddaughter was diagnosed with restrictive cardiomyopathy, age 3, and congenital transplant. And we were told, she was on the Great Northern Street, we were told that it was most probably a virus that attacked her heart. I'm interested because she's got 2 siblings, and they are tested and echoes and catheters annually at Great Northern Street. There's never been any question about whether there should be any genetic testing. Do you think there should be, as a family? Because that's never ever been a question. Or is it kind of too late now? We were just told, oh, it's probably a virus that attacked it. And when you're told, your child has been diagnosed, 1 in a million, that's for sure.
I mean, I think almost certainly, if that happened now, almost certainly they would do genetic testing. Was it a number of years ago, or was it?
She's 7 years on now.
Yeah, so things have changed a lot. So the whole genome testing wasn't around in the NHS until a few years ago. It's probably Dr. Kasky, who's the cardiologist in charge, who's a very good cardiologist, and I'm sure he would be thinking about that. It's always difficult doing genetic testing in children because they have no way of inputting into what the result is. So, for example, whole genome testing, those of you who have gone through the 100,000 genomes process will know that you can look for the heart genes, but you may pick up, say, a BRCA mutation, which gives you an increased chance of breast cancer. And you've got to know, do I want to know that or do I not? Now, BRCA mutations, that's a good example because it's pretty nasty and you probably would want to know it because then you can hopefully prevent yourself getting breast cancer. But what about one that, say, gave you a predisposition to supporting the Scottish rugby team for the rest of your life? And that's a very difficult thing to do. Would you want to know that was your fate or not? So, I mean, that's obviously a frivolous example, but there are genetic changes that you may or may not want to know, and it's good to have the patient to have input into that, which you can't do with the child. Having said that, with a condition like restrictive cardiomyopathy nowadays, I'm pretty sure we would be offering genetic testing in that case, and they can still come back and do it. That's not a problem. You can still check. The genes will not have changed. So finally onto this Takotsubo cardiomyopathy. This is the Japanese way of why they use this to catch octopuses or octopi. I have no idea, but they do, apparently. And this is sometimes known as stress cardiomyopathy, broken heart syndrome, apical ballooning syndrome. It's got a number of different eponyms. And this is a Takotsubo pot. And you can see it's got a narrowing up here. And the reason for using this is it looks like what the heart looks like with this Takotsubo cardiomyopathy when you drop some dye into it through a catheter. It balloons down here and there's a narrowing up here. And this was the first paper, not all that long ago. 1990 was the first description of this in a fairly obscure Japanese publication. And it presents with similar symptoms to a heart attack. So you come in with a chest pain. It's almost always women, not always, but almost always. And curiously, there's an emotional, or often an emotional or physical trigger, hence the broken heart syndrome. There's new ECG changes. As I say, it's mostly postmenopausal ladies. And this is what it looks like. So this is the Takotsubo pot. This is the angiogram when it's relaxed. That's diastole. This is it when it's contracting. And you can see the narrowing of the neck there, and this bit's ballooning. Whereas the normal angiogram in the left ventricle would look like this one. This is actually the same patient 2 weeks later, which is back to normal, and which shows that in most cases it reverses. So the narrowing has disappeared. That's what a normal left ventricle looks like when it's contracting. This is it with it ballooning, but this sort of narrowed area there. So most curious condition. How does it present? Well, it's indistinguishable from a heart attack. You get heart attack symptoms, severe central crushing chest pain, shortness of breath, dizziness, and fainting. And I'm not sure how well you can see that. Not sure how well I can see that, but that shows some of the triggers, the physical triggers here, and the emotional triggers there. And so it can be after a bereavement, it can be after some sort of frightening event, watching Scotland lose to the All Blacks if I'd been a lady, I'd almost certainly have had Takotsubo cardiomyopathy. And so there's a variety of different things that there's usually some sort of precipitating event. Sometimes it can just be a physical event. It can be being unwell for some reason. It can be in a car crash or something like that. But there seems to be these triggers. And the common thing about these triggers is an outpouring of catecholamines, of adrenaline, basically, a high pouring out of adrenaline. This is the graph showing the age versus the gender. So females are the light blue, males are the dark blue. Most heart attacks are in men. They're much more common in men than women. But here you can see in Takotsubo cardiomyopathy, it's much, much more common in ladies. And it right up into the elderly. There's patients here who in their 90s to 90 to 95, but also even right down to young people who you would not expect to be at high risk of a heart attack. Why is it there? Well, there's the question, and we don't really know. We know that there's an outpouring of adrenaline for some reason. This particular graph shows, it's got lots of jargon terms, the hypothalamus and the pituitary gland. That's where the stimulus for adrenaline comes, so it goes down into the adrenal glands, which produce the adrenaline. And you lead to this vigorous overcontraction of the heart, which leads to this transient cardiomyopathy. And that's the point about it, is that inevitably gets better. And so if you did have these symptoms, you'll be taken to the catheter lab. The cardiologists, 24/7 and essentially everywhere in the United Kingdom now, you're likely to get an angiogram if you go in with central trussing chest pain. And so they drop dye into the coronary arteries. Usually there's a narrowing in the coronary arteries, and you can stretch that open. In this case, the coronary arteries are usually normal. Beware of that, because the older you get, I will have coronary artery narrowings because I'm the age I am, and the older you get, the more likely you are to get coronary narrowings. That doesn't mean that it's not Takotsubo cardiomyopathy. So there may not be an acute infarct related to a complete block of the coronary arteries. So it's this interaction between adrenaline, stressful event, overcontractility of the heart. How's it diagnosed? Well, I've shown this picture earlier. This is the left ventricle angiogram showing this sort of ballooning at the bottom and the narrowing there, just like the Takotsubo pot. And there's doctors all get together and they produce these international criteria, which are mostly what I've said earlier. So transient is a feature of it. So transient left ventricular dysfunction. The left ventricle doesn't contract properly. It's reduced function or it's abnormal function. And you get this apical ballooning. It's like blowing up a balloon with the center part that doesn't actually open. There's an emotional, physical, or combined trigger. There may be neurological problems, such as a hemorrhage in the brain, a stroke. And pheochromocytoma is an adrenaline-producing tumor. So where there's a tumor in the adrenal glands that produces lots of adrenaline, and that can be associated with Takotsubo cardiomyopathy. You can do these various blood tests looking for troponin, which is a substance that leaks out of damaged heart muscle cells, and that's usually elevated. And just to point out, you can have coronary artery disease. That doesn't mean it's the cause. How is it treated? Well, like everything in medicine, again, doctors have got together and these are the things you do, most of which is fairly self-explanatory and most of which is just supportive. So you use ACE inhibitors and you use diuretics if necessary. What you don't do is give anything that will make the heart contract more vigorously. So if you have a low blood pressure and you give adrenaline, which we sometimes give if the heart's not contracting properly, that will make Takotsubo cardiomyopathy much worse. So you let the heart relax, give it time to recover. You treat any arrhythmias as and when they develop, and that's the same for all the arrhythmias really. And remember about blood clots, and you would often give an anticoagulant. What tends to happen? Well, mostly these patients get better. Usually it gets better and disappears and you get back to normal function. You don't need to do anything else, and often the medication you can come off after several months. But there's a small chance of it recurring. So again, that takes you back to, is there a genetic component? Is there something in an individual that predisposes them? Clearly, every time Scottish ladies watch Scotland play rugby, they don't all end up with Takotsubo cardiomyopathy. So there may need to be a genetic predisposition. It may not just be everybody that happens, and we don't know what that is. And that goes on to the question, does my family have it? There's really no familial incidence. It doesn't seem to run in families. If your aunt had it, doesn't mean you're going to get it, generally. I'm sure there's exceptions to that. So with Takotsubo cardiomyopathy, there's lots of questions. We're just starting to understand it. I think it's been around forever, but we've only just started to understand what it is and diagnose it. Why is it mostly women? Why do women get it and men don't get it? We really don't know the answer to that. Is there a hormonal element? Although it's postmenopausal women, still could be a hormonal element. Is there a specific treatment? Again, we don't know. Is there something you can give that will stop it if you treat the adrenaline surge? We don't know the answer to that. And is there a genetic predisposition? All questions which hopefully we'll learn and be able to answer in the next few years. And what is the role of triggers? Why is it an emotional or physical event that causes this? And is it something specific? Is it chaos theory where you need to have watching Scotland get beaten plus have a virus infection or something? Is it a combined thing, or is it just one thing? We don't know the answer to that. So we've talked about LV non-compaction, we've talked about restrictive cardiomyopathy, and we've talked about Takotsubo cardiomyopathy. Yep.
Could I ask 2 questions?
Of course you can.
Okay. First of all, regarding the research with Takotsubo, my understanding was, if you sort of break it roughly into a third of causations, there's a third physical, slightly less than that, it's the emotional element, but for a third of patients, there's been no evidence whatsoever. And I'm just sort of wondering, there's an awful lot of research that's been done and still being currently done about the emotional stress side, a little bit less than the physical side. I just think, wouldn't it be really, really useful at some point in time if the research was actually done to know the causes, because there might be an underlying thing, and I feel that there's just so much stress put on the stress element, and I don't understand really why there's been no research that I'm aware of in those really interesting patients where there's no known cause at all.
Yeah, I mean, I think you're absolutely right. And one of the problems with Takotsubo cardiomyopathy is it's a bit like a heart attack, but heart attacks are extremely common. It's quite easy to do research on heart attacks. Every hospital is a constant stream of people having heart attacks. Takotsubo cardiomyopathy is not extremely common. And therefore, it would require one research team to do a multi-center trial of Takotsubo cardiomyopathy. And these things do happen, but they're time-consuming, they're expensive, and they're difficult to set up. So people will often go to the easier things to investigate. But I'm sure that will be being done at some point in the future. And you're absolutely right, that would be entirely appropriate.
And my second question is really on behalf of the women who don't recover. I run a support group and we've got over 3,000 women, and on a daily basis, women are posting and saying they are 3 months on and 6 months on, and they're still very, very symptomatic. And then when they go back to hospital and they present, they are told so many times, is down to stress, go away, get your stress levels under control. Those who are lucky enough, who do have an understanding cardiologist, for instance, and they go on to have further testing, they're shown, and in a number of cases, they've got microvascular disease, or they're having troublesome arrhythmias, or the Takotsubo event left them with mitral valve issues as well. But there are a lot of very, very desperate women who are still symptomatic and being told, is it all down to your stress? So what would your advice be as a very, very good cardiologist to those women?
Well, I mean, the first point is, in your group, if you've got 3,000 ladies who've had Takotsubo, there is a research opportunity. It's something that I'm not really involved with because I tend to deal with the other form of cardiomyopathies, but that's a research opportunity to use your contacts to start looking in things like genetic factors and so on. You're absolutely right that there is a microvascular element to this. So it's so-called endothelium dysfunction. Endothelium is the lining of the blood vessels, and initially we thought it was just a lining, a sort of membrane. Actually, it's very, very metabolically active, and it's the lining of the blood vessels produce nitric oxide, which causes the blood vessels to dilate. Most modern diseases of modern life are related to endothelial dysfunction. Diabetes, for example, coronary artery disease, where the blood vessels get stiff. So there is huge opportunity to do that. I think you're absolutely right. It's just a matter of getting the right person to start looking at it. And I would encourage you to persevere with that. You look on the literature. Most of the literature is now online and you can have access to it. Find the guy that's writing the paper on Takotsubo. Say, look, I've got 3,000 ladies. Would you be interested in looking at our patient group? Absolutely.
And when they mention the honeycomb effect,
sorry, can I just interrupt? We use the microphone just for the camera.
No, this is a bit grown up for me.
When they mention the honeycomb effect, what does that mean? How does it affect the heart?
To be honest, I'm not entirely sure what's meant by that, the honeycomb effect. It's,
It's like honeycomb. The heart is developed like honeycomb.
you mean in the context of Takotsubo? Or?
No, in the LVNC.
Oh, LVNC, oh right, oh
Sorry,
yeah.
sorry,
Yeah, so I was trying to think honeycomb in
Sorry.
Takotsubo. Yeah, that's the crypt, the trabeculation. If you think of a honeycomb or where you've got these little, instead of being a smooth wall, it's going in and out. That's the honeycomb effect, yeah. Yeah.
Other colleagues with questions?
Yeah, so over there, I'll just show you the picture of our, just to show, these are the old, these are the former health secretaries, and a guy called Steve Barclay is apparently now our health secretary. I typed into Google Steve Barclay to get a picture of him. This is what came up. I hope this is not the Steve Barclay that's our health secretary, but who knows? But that, you type into Google Steve Barclay, you will get this picture. Sorry.
I'm one of those that there was no obvious trigger for my Takotsubo, but I'm just interested to know why my pain moved around. Why does that happen? It started here, then it went there, then it went across my back, then it went away, then the next morning it came back here, and then it came back here. Why does that happen?
Why?
Do you know why?
I mean, it's interesting. So most of the stuff we know about heart attacks and heart attack pain comes from men. And it's absolutely clear that ladies present in a slightly different way, which is why even with the conventional heart attacks with a blocked coronary artery, often the diagnosis is made late in ladies versus men because the symptoms are atypical. It's atypical for men, but of course, you're not men. And so what you're describing is actually quite common. Why it happens, I'm not too sure. I mean, the classic crushing central chest pain going down the left arm, that's a man thing. It's often not that in women. I hesitate to suggest why that might be the case, but it certainly is the case.
Yeah, I mean, when I went to A&E, the actual doctor he was a bit impatient with me, and you know, they have a rough time in A&E. But he's saying, I'm trying to find out if this is muscular, and I just wasn't responding because I was so tired. So he wasn't even looking at my heart, and it was only when a nurse looked at my blood result that suddenly it was panic. And,
yeah, I mean, classically, doctors, if they're not sure, they say it's a virus infection, it's stress, or it's a panic attack. And that's because we don't quite know what things are and why it's happened. So you just have to persevere. But we are learning more about these things. But anybody who's visited A&E recently will know it's a war zone at the moment. It's absolute chaos, people in trolleys all over the place. So contact
that
Mr.
doctor
Barclay
learned something that night.
Yeah.
Other colleagues who might want to ask a question. Lady here and then the lady here.
The trabeculations in the LVNC, they are meant to smooth out, are they, before we're born?
Yes, so these are present in the womb.
Yeah.
Sort of.
So is it a bit like a birth defect as well then? That the fetus hasn't formed properly?
The heart develops in the womb. So the beating heart's present right in the first few weeks of life, but it's a tube. And then the tube gradually septates and bits rotate, and the lining of the heart goes from being these big trabeculations to disappearing. So it's a developmental issue.
Yeah.
But it's genes that cause the development.
Right, it's genes that stop it from...
Exactly.
Yeah. Lovely, thank you.
You pass the microphone forward to this lady.
Well, I have an exercise-related question. Is it best for the exercise session or now?
Whichever you prefer.
Now, because you're
an expert. I have LVNC, and so has my friend. Now, I've been told that with respect to exercise, I had to give up a lot of the exercise I used to do. and I was told that I shouldn't raise my heart rate. I should try and keep it around 100 to 110 beats per minute. I did that for quite a while. I put on a lot of weight. I went back to him and I said, this isn't working. I'm really missing my exercise. And he then said to me, sort of shouted at me, don't go over 135 beats, absolute maximum. But my friend hasn't been told anything about exercise at all. And other people I know, I spoke to a gentleman who's got it in Plymouth, and he cycles. So what should I be doing?
First of all, your consultant should not be shouting at you.
Oh, he's horrible. He's horrible.
If your consultant shouts at you, shout back at him.
Yeah.
The second thing is that doctors are not taught about exercise physiology. They're not taught in medical school. They're not taught in cardiology training. So I did a master's in sport and exercise medicine to learn more about it. And that's part of the trouble. It's far easier to say no to something or just not to say anything than to actually give detailed advice. The first thing I'd say, it depends a bit on your individual situation, how well your heart's pumping and whether you have arrhythmias. First thing I would say is you should have an exercise test. They should see what happens when you're on a treadmill.
Yeah.
If you find that actually you're coping pretty well, that's great. You can probably do a bit more. If you're having lots of abnormal rhythms, the sort I'm getting, you should probably do a bit less. And so it depends. So you need, but every cardiology patient should have a personalised exercise prescription. That's not just me saying that. That's the American Heart Association, the American College of Cardiology, and indeed the European Society of Cardiology. There's a very good document. I say it myself because I wrote part of it, but it's published 18 months ago from the European Society of Cardiology. It's open online. It's talking about competitive exercise in patients with heart problems. There's a section on cardiomyopathy.
Thank
So with the arrhythmia, if it doesn't go up too high, like it doesn't go up to 180, if the arrhythmia only goes up to 110 or 120 of the natural arrhythmias of the heart, then can you not exercise as long as you keep an eye on how high your heart's going?
Generally, you being active is a good thing. If you become unfit, then your heart will struggle more. What's more, so I would tell all my patients, almost without exception, that when you see a lift and when you see stairs, go up the stairs and overtake the guy in front of you. You'll be hot and sweaty, but that will keep you fit. Brisk walking is as good an exercise as any, but for people that want to do more exercise, for example, a lot of us exercise for our brain more than our heart, then you want a specific exercise prescription. To do that, you have to have an exercise test. And again, that's European Society of Cardiology. It's standard advice. So it's just that most consultants, to be fair, they're busy. They have 101 things to do. They're so busy trying to work out what drugs you're on, are you on the right drugs, etc. Is your defibrillator working, etc., that they forget.
I think we're coming to a point where we're going to need to take a break. Graham, Professor Stuart, can I thank you very much for a really...
Thank you.